My name is Rami Al-Saidi, senior optometrist working at Ohad Hospital in Medina province. Today, inshallah, we'll talk about the recent development of contact lenses in the field of therapeutic options, myopia control, drug delivery, and contact lenses that can be used to monitoring diseases. This is my timeline, inshallah, which will be divided into 5 sections: scleral lenses, stem cell delivery, myopia control, drug delivery, and biosensor contact lenses. First of all, I would like to give you a classification of contact lenses based on purpose. All of you knows that contact lenses can be used as an optical correction, and there is a contact lenses can be used to correct the low vision. In my topic today, inshallah, we'll be focusing on therapeutic options and biosensor, which is ocular surface disease, myopia control, and myopia control, drug delivery, stem cell delivery, and the biosensor contact lenses, which is a part of smart contact lenses. The first part of my topic is the scleral lenses. I'm not going to talk about the optical correction for scleral lenses, which some of you knows that scleral lenses will be used with keratoconic patients and irregular astigmatism. In this lecture, inshallah, I'm going to talk about the therapeutic options for scleral lenses, as well as the drug delivery for scleral lenses. This is a timeline of scleral lenses, which will, in 15th century, Leonardo da Vinci, the scientist Leonardo da Vinci, who had the first idea about scleral lenses, but he did not produce his prototype. Then in 18th century, Friedrich and Albert Müller, which is a Germany scientist, designed the first scleral lenses, which is made from brown glass. This scleral lenses caused pain and discomfort. In 1940, a BMMA material discovered, and with the low DKT, which is oxygen permeability, and they shows corneal edema and new vascularization with these lenses. And because of that, the scleral lens is disused in 1970 and replaced with soft contact lenses and RGB. In 1983, Australian scientist, it's not working. Yeah, Australian optometrist Don Eskill, he is the first one who made scleral lenses from the two material of RGB lenses, which is eventually known as the Gelflex. 1994, the first scleral lenses has approved FDA, which is manufacturer of Boston scleral lenses. And recently, scleral lenses has been used as a therapeutic option, which is my topic today, inshallah. The good question would be asked is, why scleral lenses is very helpful for therapeutic options? To answer this question, there is 4 elements, so it's 4 factors. The first one is sclera does not touch the eye at all, does not touch the cornea. And because the liquid reservoirs here, the cornea is still healthy, and the sclera gives a permanent supply of tears. The third element is the protection. Scleral lenses can be used as a protector, not only as an optical correction. And the last thing, which is all of you know that, it's optical correction. This is some of the uses that scleral lenses can be used with, which is a case of Stevens-Johnson syndrome, chronic graft versus host diseases, a neurotrophic keratopathy, Sjogren's syndrome, and then recently scleral lenses can be used as a system to drug delivery system. This is example of a drugs delivery system with a persistent corneal epithelium defect. In 2014, 2 authors, Paulin et al., evaluated the scleral lenses with overnight wear. What they have done, they merged 2 antibiotics prophylaxis with saline solution to fill the gap of the sclera, and asked the patient to wear the sclera for 24 hours. Then they shifted that to soft bandage contact lenses during the sleep. They asked the patient to wear for 24 hours until the rehabilitation achieved. then ask the patient to wear soft bandage contact lenses during a sleeping night. What they have found is that after 8 days, the corneal epithelial defect here has treated completely, and as well as that, due to that factor, the visual acuity also has improved from 2400 to 2020. Another example of the scleral lenses is that can be used as a protector. This is a case that has incomplete lid closure. 18 patients were investigated in this case. They used artificial tears, and the visual acuity has improved from 2080 to 2035. Ocular surface disease index, which is a scale for dry eye, has improved also from 55.6 to 25. Corneal staining also has improved from 2.7 to 0.6 out of 4. The next slide, the next part of my topic, inshallah, is a stem cell delivery. In this case, or in this study, a researcher in 2015 from University of New South Wales, they have done a new thing. They cultivate patients on a stem cell on the concave of soft contact lenses. They used the cultivating with a mixed with antibiotics, and they used a contact lens material called Latrafelicon from Cibavision. These lenses took 16 days, or these cells took 16 days to colonize, and 16 patients were underwent this study with a duration from 1 to 6 years. The result for this study was amazing. 67% of these cases has a successful rate of transplantation. The successful criteria was based on restoration of transparent cornea. There is no new vascularization, no recurrent or persistent epithelial defect, as well as the visual acuity. The patient who had failure with the transplantation, they found that they had previous of chemical burns on their cases. This is one of the example of these cases, 77 years female with the right eye, and the cultivating took 10 days to culture. The new vascularization here was the before, the treatment after 5 to 6 years of stem cell delivery. Another example of a patient with 65 years female. This patient had the stem cell deficiency with a contact lens overwear. This is the case before, and this is the after 1.6 years. In this case, the contact lenses were a cause and a remedy. The third topic of my lecture, inshallah, is myopia control. I think all of you knows some of facts about myopia control, which has a high prevalence in the worldwide recently. The causes of myopia control based on parental influence, ethnicity, no work activity, lack of outdoor activity. And there is some interventions that use with the myopia control, pharmacological therapy, spectacles, contact lenses. But today I'm not going to talk at everything, but I will be focusing only on contact lenses. To give a small review about myopia, this is a case that has uncorrected myop. The image falls behind or in the front of the retina, and the image in the periphery falls behind that. With a traditional correction, which is a single vision, contact lenses or single vision spectaculars, we correct the central fovea, but we still have hyperopic defocus in the periphery. With the optimal correction of myopia control lenses or spectacles, we do myopic defocus in the peripheral area, and also we correct the central vision. This is a diagram shows that the effective of soft contact lenses and orthokeratology with outdoor activities, ATROPINE and spectacles. which shows that high effective measurement with controlling myopia. Recently, this is the new contact lenses that have been used to control the myopia, which is a dual focus contact lenses. This contact lens is called MySight. I think it's manufactured by Cooper Vision. In this lens, there is 3 zone, which is under name C1, 2, 3, and there is treatment zone T1 and T3. These lenses create myopic defocus in the central and in the periphery. A study has been done, the efficacy or the evaluate of this lens for 10 months. They found that the spherical equivalent with these lenses was lower than single vision distance glasses, and the axial length also was very high. Sorry, for this one, but it was lesser than the single vision. Another example of contact lenses are contact lenses called defocus incorporated soft contact lenses. A study has been done to evaluate the efficacy of these lenses. A study has been done for 2 years. These lenses create myopic defocus in central and periphery. What they found, the authors, that there is a 25 reduction with a spherical equivalent refraction compared to single vision. And also there is 31 reduction with the axial length compared to single vision. But the problem with these lenses that with the low contrast, there is a statistical difference and for both distance and near. But these differences were not a clinically difference. The third example of myopia control lenses, or the recent things about myopia, is a lens called extended depth of focus contact lenses. There is IOL contact lens. There is IOL lenses that used to implant, which is similar to these things. Brian Holden Vision Institutions has the novel technique for these lenses. These lenses used as a prosbyopic contact lenses, but they still they're still doing a clinical trial for these lenses for myopia control. The advantage of these lenses to minimize ghosting, double image compared to the multifocal contact lenses, and also to reduce the higher order aberration to optimize the retinal image. My fourth topic is a drug delivery system. With the drug delivery system, this is the traditional way of the traditional drug delivery way, which is eye drops. The disadvantage of these eye drops is that 5% of the eye drops penetrate the cornea. The 95% of these drops go away. Sleep prevents installation for long periods, and there is many individuals have trouble correcting applying the drops. But the good question would be asked, how to deliver the drug through these contact lenses? To answer these questions, there is 5 important methods. There is others, but this is the most important 5 methods. The first one is the soaking method. With this soaking method, in 1960, they used hydrogel material. They found hypoxia and improved residence time, but failed to sustain drug release. The second method is a bulk barrier. They use vitamin E to barrier this drug delivery. What they found that there is increased release of timolol and anti-inflammatory drug. The third one is a functional memory, which increase the interaction with the drug, and the sustained drug delivery for this method was 24 hours for ibuprofen. Once you give the patient the contact lenses, the ibuprofen is still on that patient for 24 hours, and diclofenac takes 5 days to release. The fourth one, which is one of the new methods, is the colloidal nanoparticles. In this method, there is a high affinity for the drug of interest, but there is loss of optical clarity and also can cause irritation toxicity. The sustained drug for this method is 22 to 4 weeks with the timolol drugs. And the last method of the drug delivery is molecular imprinting. This is the most important method to use to drug delivery, which increase drug loading and deliveries with a high optical clarity advantage and limited to low molecular weight. This is the way of imprinting methods. They replace the drug here with this is the target drug, and they replace it with the template drug. This is a schedule shows that acetazolamide with this method takes 1 to 2 days, diclofenac 5 days, ethoxyzolamide takes 2 days, hyaluronic acid 40 hours, hydroxypropyl with silicon hydrogel takes 62 days in a contact lenses. Timolol depends from 1 hour to 9 hours with the hydrogel contact lenses and 30 minutes with the silicon hydrogel contact lenses. Last part of my topic is the biosensor contact lenses. We have to understand that biosensor contact lenses is a part of smart contact lenses, which has a sensor or device inserted on a lens, could utilize a biological molecule or living organism. This biosensor can detect early disease and can monitoring intraocular pressure, vascular monitoring, and pathology testing. This is the first example from the fourth. Intraocular pressure lens, which is named as Sensimide triggerfish. 13 publications were used to investigate these lenses. The advantage of these lenses, or the mechanism of these lenses, to take the changes of dimension of the cornea, and it takes 24 hours for reading. It gives help to a clinical session, but one of the disadvantages, it does not come with millimeter mercury, but as voltage wavefront, and the cost very high, with around 6,000 pounds for each contact lenses. This is the contact lenses. There is antenna attached to the eye. These lenses send the data to the PC, which is available in the market. These lenses are available in the market. The second example is the contact lenses that can be used to measure the oxygen level in the blood. It's not available yet, but it's under clinical trial. The third example is contact lenses also used to evaluate the vascularity, the vascularization and cardiovascular disease. Still have one example only. This lens is still not available in the market. And the last example of my topic today is pathology testing, which is blood sugar level contact lenses. These contact lenses use a pinhole here to measure the tear film fluid, which will be available in 2020, inshallah. This is a summary of my topic today. I need to focus only on the complications. We have to take actions toward these contact lenses. Thank you.
Hi, hello, good afternoon. I hope you're still awake to listen to my talk today. Give me 1 second. Yeah, we're running a bit late, so I thank the doctor who spoke before me, because he already discussed some of the things on my slides, and I hope that if you have any questions, if we run out of time, you can send it to me through email. And I'll be here again in the Ortho-K workshop. So I'm Dr. Jocelyn Samson. I am an OD and a licensed nurse as well. And I'm the first fellow of British Contact Lens Association in UAE and in the Middle East. So thank you very much, Dr. Yaya and the whole organization of Red Sea Ophthalmology Symposium for inviting me today. So I am one of the nerds who is trying to control myopia, and we're this group of nerds who's trying to give lectures around the world, including a friend of mine, Kate, in one of the slides of our colleagues here. So I'm very happy to see her name. And I hope after this lecture you will be all fighting against myopia. So my title is Keep Myopia Away, Go Outdoors and Play. It's a myopia control and management awareness. So why such a boring topic? They brought Jocelyn all the way from United Arab Emirates just to talk about myopia. What is this? I didn't sign up for this. I didn't pay for the conference for just talking about myopia or listening to myopia. Are you kidding me? So this is how we look like at this time of the day. Yeah? Okay, so what about myopia? So whenever a patient comes to our clinic, okay, and then you see, this is us, or the female version of us. So whenever we see them, okay, fine, myopia, or wearing eyeglasses, parents are myopic, what do we usually do? We do retinoscopy. Who amongst us are still doing retinoscopy in the clinic? Well done, you. Okay, so and then this is us again after doing some eye tests. Actually, I use this picture for when you're doing eye tests on keratoconus, because basically this is what we look like after, isn't it? And then after that, we check for binocular vision, and then we check for the eye health, and then after that, we give them eyeglasses and contact lenses. Kalas, that's it. So that's the end of my lecture. No, I'm kidding. So what? So our learning objectives today is to understand what is myopia control. When you say myopia control, what do we mean by it? And then we want to be updated on the studies conducted related to protection from and progression of myopia. And how are we going to reduce the risk of high myopia? And what are they anyway? Okay, so this is our kids, our nieces, nephew. When you walk through the restaurants, you know, like in Dubai, I live in Dubai. I've been living there for 10 years. I just look like a 14-year-old, but I'm actually 42-year-old. Okay, I've been an optom for 20 years. So this is how it looks like when we walk in the restaurants. Whenever a child is crying, mommy will give an iPad or a phone. Kalas. That's it. They're happy. So what? Okay, we can afford to buy iPad. Okay, so what are these pictures? So in 2015, World Health Organization, together with Brian Holden Vision Institute, said that in 2010, there are already 2 billion myopic in the population. So what? It was forecasted that in the next 35 years, there will be 5 billion. So in 2050, there will be 5 billion, or half of the world population will be myopic. And then 20% of those will be at high risk of having all the risk for high myopia, which are macular degeneration, retinal detachment, posterior subcapsular cataracts, and glaucoma. That's why we're concerned. So, childhood myopia prevalence. I am from Southeast Asia. I'm a Filipino. So, when I was born in optometry, all we talk about is short-sightedness in that part of the world. Is it only in Southeast Asia? You will see in this slide that around the world, all the studies about pedia, you will see the percentage. I wrote here where I got it. It's a study made by Pan and his group. So you can take a picture of it and you can read about it. So it's ongoing around the world. There's an increase of prevalence of myopia, not only in Southeast. So the increase of prevalence in myopia, who amongst you are, let's say, which age? 30 years old and up. I don't know, you don't want to raise your hand, right? Okay, who amongst you can still remember this computer? Oh my gosh, very few hands. Okay, so that one was introduced by Steve Jobs. He's already dead, but we always blame him. Okay, so ever since he introduced that computer in the late 90s and 2000s, here we are. Who amongst you has a handheld phone? Mobile phone? All of us, yeah? So ever since he introduced this, there was a surge of short-sightedness in the world. So in America, so is it only in Southeast Asia? So they did a study in America, and then what they found out is on the 70s, there's only 25% myopic in the population. Whilst when they did a study from 99 to 2004, it ballooned to 17% in a span of 30 years. And if you see the year here, that's when Steve Jobs introduced the beautiful computer. Okay, so what? So the risk of ocular pathology in high myopia, if you see this on my slides, as the myopia amount gets higher, it increases the risk of having these pathologies that can cause blindness for our patients. So this is according to this study and by Philcroft in 2012, and you see the name of Kate there again. So she published, if you can check with Dr. Google, the title of this, Myopia Control and Contact Lenses in Practice. I actually printed it out because every time I see a patient, children or the adults that has myopia, and I talk about myopia control, I give them a copy of this. Although it has a contact lens on the title, it discusses everything that comes out of my mouth, and it's a very good tool for you to share to your patients. So as you see here, myopic maculopathy, if the prescription's -1 to -3, it's only twice the risk of having myopic maculopathy. But if you see, if it goes to greater than -7, it's 127 times the risk of having it. This is one of the things that you saw on my first slide. This posters is stuck on my eye test room so that it's easier to explain to patients. These posters are stuck in every school in Singapore because there it's already 85% that are myopic in the population. In the Middle East, it's quite low, the awareness. I don't know if you'll agree with me. Yeah? 85%, 35% in the Middle East, thank you. So yeah, 35% in the Middle East. But whenever we see a patient, you'll see later what are the modalities that how to control myopia. Are we all talking about controlling myopia in our eye test room? So this is why I'm here. Okay, give me 1 second. Excuse me. Back one, please. Okay. So when we say myopia control, what do we mean? Does it mean no change in myopia? If you're 8 years old, you have -1. At 21 years old, if I control your myopia, you're still -1. Is that what we mean? Or do we mean that we just want to slow the progression of myopia? Okay. So the significant myopia control, according to Wallin in 2012, Wallin's research, is that an example is if a child is diagnosed at -1 and progresses -0.50 every year for the span of 8 years, if the myopia progression is slowed by 0% or we didn't do anything at all with this child, what happens is after 8 years old, so by the age of 16, this child will have -5. Okay. At 16 years old, in your experience, do you still see progression of myopia in your patients? Yes. Yeah? It's possible, it's yes. Okay, so if uncontrolled, -5 after 8. So at 16, this child will have -5, which is already considered as high myopia. At 25, if you control it by 25%, I hope you will hear me even without the microphone. If you control it by 25%, good enough, you have -4. If 50%, -3, and so on and so forth. Of course, if 100%, which is one of the holy grails that we have to still find, at 16, this child will still be -1. But unfortunately, we haven't found a 100% control for myopia. So this one is very significant whenever we talk about myopia progression and control as well, is Noel Brennan's research, and it was posted in the BCLA abstracts in 2012. I don't know what's happening. Okay, right, so he said, according to his research, that if we reduce the rate of myopia progression by 33%, we'll be controlling or reducing the frequency of high myopia by 73%. But if we were able to control the progression of myopia or reduce the rate of progression of myopia by 50%, we will be able to reduce the frequency of high myopia and the risk that encompasses it by 90%. That's why the soldiers of myopia always wants to reach 50% and up for the modalities. Okay, so what are the risk factors? All of the optometrists, we know this, yeah? So genetics, if one parent has it, twice the risk of the child or the children having it. If both parents has it, 4 to 5 times the risk. But in 1994, Lam made a study and found out that grandparents only have 5%. 5% of the grandparents only have myopia, whilst there's a lot in their generation. So what's happening here? That's why it's theories, right? So who amongst you remembers who this guy is? Who this fella is? When I asked this in United Arab Emirates, they all told me it's boorish. Everyone has a nightmare on that. It's an author of a book, very famous book in optometry. That's not boorish. This is Cherning. Okay, so Cherning was the very first one who said that only the intelligent people have myopia or can have myopia because and that was in 1882. It's not a big. It's not a new thing that everyone's talking about myopia control. So Cherning is the arch enemy of Helmholtz. You remember in accommodation, right? Okay, so he said that those who are always in front of the computer, no, that time there's no computer, but the accountants and the ones always reading, they are the ones who tends to develop myopia, whilst the ones who are farmers, they tend to be less myopic, mostly hyperopic. Binocular vision and peripheral defocus, those who have esophoria and high accommodative lag, they have the potential as well to progress as myopic, even if, for example, you catch a child at 6 years old having plus 0.50, if they have esophoria and high accommodative lag, you have to watch out for them because they can be progressing to myopia if uncontrolled. Peripheral defocus, so that was discussed by my colleague a while ago, if you remember, and we will discuss it later as well. So what are we going to do about it? Outdoor activity. It's one of the biggest things that we tell to our patients, parents, and our patients as well. So these are the studies that we should be reading. I want you to take a picture of it so that you can read about. And it's proven that if we push the kids to go more outdoors, there's an increase in dopamine and vitamin D that slows the elongation of the eyeball. And all of these studies proves that, okay? So, important issues, outdoor activity is definitely protective, and then they will usually ask you, how many minutes should we push our children to go outdoors? It's, by research, 1.5 hours outdoors. Whenever I attend conferences and lectures outside UAE, I always tell them that my children, which is my patients, they will die first of heat in UAE before they have myopia. And I asked about intake of vitamin D because they said increase in vitamin D slows the elongation anyway. But unfortunately, if any of you knows about it, the answer to me is that there's no research yet. There's one research that they quoted in Hong Kong, but it was not as effective as kicking the kids outdoor. Okay, myopia control, is it a new thing? What did we do before? What are we doing before the search of myopia? So me, I graduated in 1996. So before, we used to give RGP lenses thinking it's the holy grail of myopia control. I'm not talking about ortho-K, but just a regular RGP lens. Then we all thought that if a patient has high myopia in Southeast, give them RGP lenses and it will be controlled. That's the best thing we can do. The other option was undercorrection, which is still famous up until now. For those who are not aware of what's happening in the world yet, so we still get a lot in the clinic of undercorrected patients, and I am one of the guilty ones who used to undercorrect my patients. If I get a minus 0.50 child, I'll tell them to use it only when they need it. If I get a minus 150, I give them minus 1. Because I'm thinking, maybe you should push because maybe I'm overcorrecting you, or maybe you should relax your eyes, remove it when you're reading. We'll see if it's true that I'm helping the patients or I help those patients or no. Then, wow. And then the next one is bifocal eyeglasses. I have to skip a lot of slides for that 10 minutes, unfortunately. What I can do for you is I can send my slides. And if you have any questions, just give me a shout, okay? So I share my slides because I want you to help the patients. Okay, RGP lenses, anything on my slide that's negative, it means it's not controlling it and pushing it to elongate more. Okay, so you see here, 5%, -5, -8. So RGP, not a good thing. Okay, under correction, how many percent? 19, -19%. So those kids who were undercorrected, the progression went faster. Okay, so I think one of my foot is in hell because I used to do that. And then bifocal or PAL, is it a positive or a negative? Positive, yay, you found it. But it's only 18%. We wanted 50%, right? And the problem with a bifocal or progressive is fine. But bifocal, the problem with that one is that the kids, they get bullied in school. So when the parents are not there, they remove their eyeglasses. I'm not a fan of progressive because there's no line. The kid still uses the upper part, and we don't know if they're using. With bifocal, you always ask the opticians to do it bisecting the pupil, right? So you know that your patients are using it. 3 minutes, I can't believe it. Okay, where does this leave us? Okay, sorry? 10 minutes, okay, it's increasing. Is it true? Okay, ATROPINE is very famous with our fellow ophthalmologists. Any ophthalmologists in the house? Yeah, okay, so it's very famous with you guys. Okay, so ATROPINE, in these two studies, ATOM 2, take a picture, but I'll send you the slides anyway. So the very famous control in progression, 77%, even higher than 50%. Why don't we do it? The only thing, so you can read here, what's happening with ATROPINE, but the biggest thing is the rebound effect. Okay, so when -1 patient placed ATROPINE, 77% control, when they stopped it, what happened? It doubled. So, okay, what they did, they decreased the concentration, and now the accepted concentration is 0.01%. But even in our clinic, we don't do it. Why? Because we cannot find it. We have to go to the pharmacy to compound it. Do we trust the pharmacist? There's no pharmacist here, okay? But we don't know, isn't it? So that's why it's not used in the clinic, in our clinic, in our practice. So for us as optometrists and those ophthalmologists who wants to control it, this one, just take a picture. This is how the eye elongates. These are the studies. Chicks, whenever we do lectures around the world, so being a part of BCLA, when we say chicks in the dark, this one, form deprivation, they place the chicks in the dark and they saw an elongation of the eyeball. We say monkeys, they place plus prescription in one eye, minus prescription in the other eye. The plus prescription became hyperopic, the minus prescription became myopic, so something like that. Okay, this was discussed by my colleague a while ago. This is the most accepted theory that we have now whenever everyone's designing a contact lens to control myopia. Okay, soft multifocal contact lenses. I'm not paid by anyone, but in the region, I'm not sure what's available here, but in UAE, Biofinity multifocal center distance and ProClear multifocal center distance, it's the off-label that we use for daytime lenses to control myopia. My site was discussed by my colleague a while ago. Thank you so much. And then orthokeratology, you will hear more about it with our colleague after my talk and in our orthokeratology workshop. So this is one of my patients. The reason why it's there, ancient Chinese, they are the ones whom we thank for ortho-K because what they did, they were the ones who conceptualized. They close their eyes, place sandbags in their eyes, and then they remove it, and then they can see slightly better. That's where the concept of ortho-K came from. Okay, let me skip this because we're going to talk about this anyway in the workshop. But as you can see, ortho-K is more than 60%. So one of the things that your patients or the parents will ask you is about infection. You ask my child to sleep with the lenses. I don't even sleep with my lenses. You want her to have bacteria or infection. So according to the study by Stapleton, Daily disposable, 2 per 10,000. Reusable, 12 per 10,000. Extendable, 24 per 10,000. So Ortho-K is 12 per 10,000, like the reusable silicone hydrogel. But if you use AUSEP, is it available here? AUSEP or ClearCare? That's what I use for my Ortho-K. In Southeast, mostly Boston. So they get more infection there. Now, in fairness, in our clinic, we haven't had one. I think it's because of the modality that we do and because we're all OCD. This one, take a picture if you want to receive my stuff, but you will anyway. So yeah, so if you can see here, everything that goes, this is also stuck in my ITES room. If you can print it and stick it in your ITES room. Everything that goes that way, see here, the only thing that doesn't control is under correction of spectacle lenses. Thank you very much. So these are the references that you can get from. I want you to all add in Facebook, if you don't mind, MYOPIA profile. You can like it because the thing is, we are this group of nerds who's, it's Kate Gifford. It's her Facebook, and then you can get a lot of studies and whatnot there, and you can join the conversation. Thank you so much. Thank you.
Hi everyone, my name is Ayat Al-Ghamdi. I am Doctor of Biomedicine candidate and I have master's degree in clinical optometry and certificate in contact lenses. So today I'm going to present my lecture, which is about is orthokeratology effect approach in controlling myopia of school-age children. This is a study, it's done in the United States. I did meta-analysis. So let's start with introduction. My colleague actually, it's talk about the epidemiology, the prevalence rate of myopia. But let me add some information, which is the prevalence rate of myopia is increased in school-age children. For example, in Singapore, at 30%, they have having 7 years old, they having myopia. So this map supports what I just mentioned. So Hong Kong considered to be higher percent. As you can see here, it's 80%. And also, let me as well skip this slide, which is the risk factor for myopia, which is genetic and environment. And there's the recent study said, which is talk about the education level, which is a very interesting study, said the prevalence rate of myopia increase, the prevalence rate of myopia increase with the level of education achievement. Here I have question why myopia progression is a concern. Because it's axial myopia. So the globe, it's become larger and it's happened for elongation. The prevalence rate of ocular disease complication, it's increased. So as you can see here, like over -6 diopter, they're having myopia. So can get the complication, which is retinal detachment, cataract, glaucoma. So here there are the many options for the myopia progression interventions, which is eye drops, spectacle eye drops like ATROPINE, or spectacle or contact lens. Today I'm gonna focus on orthokeratology contact lenses. So, what's the ortho-K keratology? Orthokeratology lenses, it's geometry lenses, geometry reverse lenses, which is change the anterior surface of the cornea to make it flatter and steepening the mid-peripheral of the cornea. And you can see here, because it's reversed from the normal, and we all know the cornea is steepening in the center and flattening in the peripheral. And here, with this surgery, we did this way, with this treatment, we did the surgery, we did this therapy without any surgery. So because when you stop wearing the contact lens, the cornea can come back. So keep this in mind. How ortho-K works? This is very controversial topic because there's one study said we just push the cornea down, while another study said we're just pushing the corneal tissue to the side. So how to use my hand? Okay. And the recent study said we are not moving the corneal tissue down, we're just moving the the water content for those tissue. So for this reason, when you stop wearing the contact lens, the water can come back to those cells. So here, patient can wear the contact lens during sleep, and when you're wearing the contact lens, we're steepening the mid-peripheral, the central surface of the cornea to make it flatter, and steepening the mid-peripheral of the cornea. So when your patient remove the lenses, can see better. So this is the shape of the cornea after we remove the lens. So I did meta-analysis study to determine the effect of orthokeratology in controlling myopia for school-age children. This is these following, it's a strategy, the research strategies after I search in PubMed database. And this is my inclusion and exclusion criteria. I include any study they have change in the axial length measurement as a primary outcome. As well, I exclude the meta-analysis study, review paper, and as well retrospective studies. In this study, I include randomized control trial and cohort study. So randomized control trial, which is I using Cochrane scale, and for cohort to using Newcastle, which is to assess the bias. For statistical analysis, I use Review Manager software, p-value less than 0.05, which was considered statistically significant. And here in heterogeneity, you can see here you can see the I-square statistic was more than 50%, considered to be heterogeneity, and considered to be not significant heterogeneity, and p-value less than 0.1. Sorry. There I did as well additional meta-analysis on 3 subgroups: different follow-up period, study design, RCT, and cohort studies. So let's talk about the result of this study and the discussion. So I identify in PubMed 308 studies in database. I end up with, after reading title and abstract, and end up with the 9 studies, which is randomized control trial and cohort studies. So here in this table, as you can see, most of the studies are conducted from Eastern countries, and only 3 of the study is from Caucasian, and the age range was between 6 to 17 years old for the children. And here, as you can see here, -5 diopter, the baseline spherical equivalent in this study with its charm, and the chin, the astigmatism high, it was for astigmatism at least 1.25 diopter. So what that means, so for this reason you can see here, they use 2 special design of ortho-K, which is partial reduction for high myopia, and toric, which is for the high astigmatism. So keep in mind the question, because we need to know whether these 2 studies affect our final result. So here, the result of the effect, this is the first graph, which is the effect of ortho-K and slowing myopia and different. So as you can see here, this is half year, 1 year, 2 year, 5 year. I don't know if it's clear here. Okay, here you can see there are heterogeneity, which is more than, we said I-square, more than 50%. So what I did random effect model to estimate this effect. And I compare as well the ortho-K group with the control group. Then I find that change of the axial length, it was it's 0.09, here 0.18, here 0.25. So ortho-K is effective for controlling myopia. Then I redid the meta-analysis after I exclude these two studies, which is used the special design of ortho-K, and I found the p-value 0.5, so no statistical difference between them. Here, as you can see, in this figure, in the effect of myopia, the most effect for ortho-K, which was in the charm studies, which is here in 5 years, here in 80, here in 25. So I have here questions. So here you can see the ortho-K is the most effective approach. So I have question. Why ortho-K has the most effective in high myopia? So please remember this question, and I will answer the question in the discussion. So here in the discussion, I can say orthokeratology lenses is effective approach in controlling myopia in school-age children during treatment 1 and 2 years. So this, I think, other colleagues, they explained this idea. But let me start with some definition. When the parallel rays, it's come through the cornea and the image and the retina, we call this focus. But when the image it's become behind the retina, we call this defocus. So this is hyperopic defocus. While when the ray is in front of the retina, we call this myopic defocus. And we know hyperopic defocus. Okay. Hyperopic defocus, what can did? It stimulate the axial length growth, while myopia, it inhibit the axial length growth. So let's compare. If we use undercorrected myopia, the image will be defocus in the center. And when you use a spectacle, it's gonna be focus in the center, while on the peripheral, it's defocus. So it's not option. But when you use the ortho-K, the all image can be focused in the retina, peripheral, and in some point, like for example high myopia, the peripheral can be myopic defocus. So here, why the most effective control was for most myopia, which is the question I answered before. Why? Let's review some important part in the orthokeratology lenses. There are three parts: the base curve, the return zone, and the landing zone. So in high myopia, when you say high myopia, that means it's high reduction of the central surface of the cornea. So in this area. So we make this area, it's flatter. And as a result, the mid-peripheral of the cornea, it's become more steeper. What that mean? That means less hyperopic defocus and more myopic defocus. So I just mentioned the duration of the treatment, which is 1 year, which is half year, 1 year, 2 year, and 5 year. So I said 1 year and 2 years is more effective. What about half year and 1 year? So when you review the physiology of this, when you're using the after removing the ortho-K, so the central thickness of the cornea, it's the most effective when you're using this treatment. So there is three in my included studies. So I said, here, it's 6.13 micromillimeter after using 1 week, the reduction, and after 2 weeks it's 12 and 19 for 3 months. So it is best to measure the baseline axial length after 3 months of wearing contact lens at least. And also because only 3 of the studies they are mentioned the CCT, so I said more study were educated for the neck. Let's back to our study for these tables. As you can see here, for 5 years, only 2 studies are conducted for 5 years. And you can see here the confidence interval. It was here, you can see the diamond of meta-analysis. It was larger. So I said more long-term studies for 5 years are required. As well, so it's very important to evaluate the dropout rate, because that can be bias our final result. Actually, the dropout rate, it's around 11 to 14% for only one reason, which is relatively small, and because the sample size, it was smaller. So that can give us the high rate of dropout rate. And all this, you can see the reason of dropout rate. And yes, and I found it was equally distribution between OK group and control group between the dropout rate. So no statistical difference between them. So there's some limitation in my studies, which is the most article, actually the article was searched in PubMed. And the second one, no double blind design, if you can remember, because the double blind, it's required for RCT studies. And the most of the study, it was from Asian children. Conclusion, in summary, I can say ortho-K slow myopia progression in school-age children during treatment duration of 1 year and 2 years. And we need more research for this one to find the RCT. And as well, the study longer than 2 years need to investigate the effectiveness of myopia. Thank you.
Starting with introduction, poor vision is a major limitation of sound enlightening in school, college condition for a student in various areas of the world. Visual impedance because of uncorrected refractive errors, exceptionally among young full grown-ups, is the second most common reason for treatable visual hindrance. Refractive errors now turn into a huge problem and numerous countries. Also, it's a weight on nations' economy, particularly developing ones. The incidence of myopia is beginning to increment, especially in East Asian countries, achieving to pestilence levels. Like in medical schools, a study in Taiwan say 95.8% of students having refractive errors, especially myope. Singapore is 89.8%. Several studies have attempted to interpret the exact or the etiology of myope, but the concrete etiology is still obscure. Some studies go to some studies go to environmental factor, some for genetic influence, and other interaction between the two. But it's still debatable because of variation in different studies. So Byrne claims that uncorrected refractive errors to be the most common visual disability over the world. Many investigations saw a solid connection between the level of intelligence and years in school participation and seriousness of myopia. Large population seemingly unaware to the problem, and would lead to progressive visual inadequacy and affect their potentials. Also, this is applied clearly to young adults who are studying in their college, universities, and suffer because of poor vision due to common error of refraction. So the index study here to highlight the prevalence of this error in medical students in our college. So our objective to study the prevalence, severity of various error of refraction, and the most common method of correction of refractive errors. Our methodology, it's a cross-sectional study conducted over 2 months on 162 students from College of Medicine. The induction of the study was by simple random sampling selection from different academic years. After giving the consent, each subject have been examined by autorefractometer. The examination was carried out by optometrist without using cycloplegia. Both right and left eye have been examined, and average of 3 readings have been taken. Reading were recorded and analyzed by species, and by using spherical equivalent was calculated as a sphere plus half cylinder, and myopia was defined at spherical equivalent at least minus 0.75 diameter in either eye. Myopia was divided into in subgroups: mild, moderate, and severe or high. Low myopia was spherical equivalent between minus 0.75 and minus 2.99 diameter. Moderate myopia was spherical equivalent minus 3 and minus 5.99 diameter, and high myopia was minus 6 or more. Hyperope was defined as plus 1 diameter or more. Emmetrope was between the two, minus 0.75 diameter and plus 1 diameter in either eye. Astigmatism was defined as minus 1 cylinder or more. Our result, we found that the myopia was the most common refractive error, and by 53.7%. And the lowest is hyperope is 1.2%, and the emmetrope was 45.1%. The subgroups of myopia, we found that mild myopia is the most common, 37%, and the moderate myopia was 14.8%, and the high myopia was the least, was 1.9%. The overall astigmatism was 27.8%, and the most common correction method used is spectacle, undisputed, and was 31.5%, and the lenses was 0.6. So the myopia was the most frequent cause of vision impairment, increasing prevalence worldwide, and in review to measure the global disparity in childhood myopia prevalence over time, considering demographic factor, they found that and the age was one of there is rise in myopia prevalence rate with age varied by ethnicity. Like in East Asian exhibited the highest level prevalence, attaining 69% at 15 years of age. Study on school children in China revealed the myopia prevalence rate ranging from 20 at younger children and to 80 at 17 years old students. Different investigation of Sydney school children indicated the ethnic contrast in myopia prevalence. Kids of Asian or East Asian ethnicity had higher rate than European Caucasian kids. So a study from KSA has examined 2,246 Saudi primary school children aged from 6 to 14 years, both gender. They found that the refractive error was 13.7% when the myopia was the highest. Another cross-sectional survey conducted in KSA, including 21 primary school with 5,176 children. The mean age was 9.5 plus or minus 1.8 years. The refractive error was 18.6%, and astigmatism and myopia was the highest. All these related studies have screened for myopia among younger children, which is my reduced attributability of myopia occurrence. In this present study, the highest percentage case was the myopia were seen among 20 years or older, and it was reported that myopia increased significantly with age. Kadiri also mentioned that there is a study that about rising incidence of error of refraction in younger age children. And our study showed the increased incidence of myopia among university students, finding in line with a similar other study. There is two studies actually, a study in Hail University and the Prince Sattam University, involved 504 medical students, and other studies 240 medical students in Marmara University in Turkey. The schedule showing comparison between the three universities. You see MYOPIA in Saudi Arabia in Hayal and Prince Sattam and Qasim University was close percentages, 53.5 in Hayal and Prince Sattam University, 53.7 in our university, which is low also, and MYOPIA was low in Marmara University. Hyporob was 2% in Hayal and Prince Sattam, 1.2% in our college, Qasim University, and the highest in Marmara University. And Emitrop was 5% difference between Marmara and Qasim. The subgroups of myopia in Marmara University, they found that low myop, which is the highest between the subgroups of myopia, by 81%, same in our study. And the Hayal and Prince Sattam study, they found the moderate myop 51.80% is the highest, and the mild myop in the second, and the high myop. Erdenists have recently proposed various treatment options for controlling progression of myopia in young population. Many other similar studies have postulated the danger of progressive myopia and various vision-threatening complications, retinal detachment, choroid atrophy, or glaucoma. Vision screening programs are vital necessity in underprivileged communities all around the world. Vision screening is generally randomly done on school children, which is a valuable methodology for perceiving potential treatable visual assortment or standard. Our conclusion, the finding in this study indicate there is high prevalence of myopia among medical students in Saudi Arabia, and the error of refraction are the most common correctable causes of blindness all over the world. An action toward screening program is suggested to pick the population affected, so to take timely measure to correct the error before it can lead to vision-threatening complications. Thank you very much.